Now I'd like to introduce our speaker for this evening. Erik Zachwieja received his Doctor of Medicine at the University of Virginia School of Medicine, followed by his residency in orthopedic surgery at University of Miami. Additionally, his fellowship training in adult reconstruction was completed at the Rothman Orthopedic Institute. Dr. Zachwieja is board certified by the American Board of Orthopedic Surgery, and he's part of Garden State Orthopedic Associates and practices out of both Fair Lawn, Mahwah, and Paramus. So welcome, Doctor. Thanks for being with us this evening.
You're very welcome. I'm excited to be here, and I'm glad to kind of talk about hip pain tonight. I understand we have looks about 30 or so folks on tonight, and so I'll be happy to answer any questions that may come up at the end of the talk as well, with regard to the talk, or in particular to you guys on the webinar, if we can keep them relatively general. So tonight I'm going to chat about hip pain. We're going to focus initially just on some generic types of hip pain that all patients can suffer from, and then the latter kind of 2/3 of the talk is going to be primarily focusing on hip arthritis, which is primarily what I specialize in, hip and knee replacements. And so hip replacement is the definitive treatment for arthritis. But we'll start out with the generic hip pain, and then we'll get a little bit more into hip replacements as we go further along in the talk. So again, first of all, we're just going to kind of briefly go over some of the main common diagnoses for hip pain, and then we'll talk about treatment options, and then we'll discuss hip arthritis, which is going to be the primary focus of this talk, with the treatment for that being hip replacement surgery. And we'll talk about what to expect with regards to hip replacement surgery and the recovery afterwards. And then we'll have some time, hopefully, at the end for some questions and answers. So these here on the left, I'd say, are probably the 6 common causes of hip pain that I see in my office on a daily basis. And they kind of start with the most mild forms, which is going to be bursitis and tendinitis, which are usually just some self-limiting conditions that we have a multitude of non-operative treatment options for. Labral tears is a little bit more infrequent diagnosis, but we'll talk a little bit about that. Avascular necrosis is a relatively rare diagnosis, but I think it is important to understand. And then we'll talk about hip fractures, which we typically see in the more elderly population. And then again, we'll talk about arthritis and focus on that and its causes, as well as its treatment options. So if I had to say what's probably the most common complaint for the hips when patients come into the office to see me, it's almost always, the vast majority of the time, it's going to be this diagnosis. And this is what we call bursitis, or trochanteric bursitis. And so this is going to be the pain that you feel on the outside part of your hip. And so if we're talking about our right hip and we put our hand down on the outside part of our hip, we're going to feel that bony prominence there. And pain in that area is what we call bursitis. And we have a fluid-filled sac that lives in that area that kind of protects the bone from the overlying muscle. And if that fluid-filled sac gets irritated, it fills up, it causes inflammation and ultimately pain. This usually is caused by either repetitive motion, so starting a new activity, going to the gym and doing something that you haven't done in a while, or because of the muscles in that area become very tight for a multitude of different reasons. And in general, that's going to be painful to the touch. Again, if you push on the outside part of your hip, patients will oftentimes complain of pain with going up and down the stairs, or particularly with lying on your side. So if you have pain at nighttime when you roll onto your side, and it's tender to the touch in that area, that's most frequently going to be bursitis. And bursitis is generally, we start off with physical therapy. We have to loosen the muscles on the outside part of the hip that become very tight. If we can loosen those up, they stop irritating that area, and frequently that resolves the symptoms. Occasionally, we have to do a cortisone shot into that area to reduce the inflammation and eliminate the pain. And very, very infrequently does this require surgery. I'd say about 2 to 3% of the cases require surgery. The next most common diagnosis would be tendinitis. And that's going to be inflammation of two of the major tendons around the hip. One of them, again, is going to be on the outside part of your hip, and those are part of your big butt muscles called your gluteus medius and your gluteus minimus. And this is going to cause similar type of pain on the outside part of the hip, but it's usually going to be with more active type of motions rather than just tender to the touch. And again, usually this tendonitis is going to be caused by starting a new activity, overusing those muscles, or if you have a trauma. Another type of tendonitis is one that we see more in the front of the hip, and this is going to be what we call iliopsoas tendinosis. That's one of the hip flexor muscles that helps bring your leg up towards your chest. And so if you have pain in the groin with that type of movement, that frequently can be iliopsoas tendonitis. Again, tendonitis is almost always treated conservatively, meaning with physical therapy and occasionally with injections, and very, very frequently they resolve with a course of physical therapy. A labral tear is our next diagnosis, and this is damage to the cartilage that lines your hip socket. In general, we see this type of diagnosis in younger patients, so usually in the 20 to 40, maybe 50-year-old range. If we're getting above 50 years old, it's very infrequent that this is going to be your source of hip pain. This diagnosis, oftentimes patients will complain of clicking or locking within the hip joint, and they'll have sharp pain that's deep inside of the groin. Frequently, it's related to trauma, either a fall or if in younger patients through exercise, they'll have a sharp pain after doing one specific movement. This also frequently resolves with the course of physical therapy. While the labrum tear doesn't actually heal itself, frequently patients are the muscles around the hip joint are actually able to compensate, and you can go on living without any symptoms, and it does not cause any damage to the hip joint. And very infrequently, again, this injury will require surgery. The type of surgery that this entails is a arthroscopic procedure with minimally invasive, a few small poke holes around the hip and putting a camera deep inside of the hip. And this is usually performed by sports medicine specialists. A somewhat rare diagnosis, but I think it is important to just mention briefly. The diagnosis is called avascular necrosis. And basically, this is when we lose blood supply to the ball of our ball and socket joint or the femoral head. And ultimately, this leads to the bone starting to die. And this causes sharp, severe pain deep inside of the hip joint. Risk factors for this diagnosis are people that have been on excessive steroid use, either chronically for some sort of asthma or autoimmune condition. Additionally, excessive alcohol consumption is known to lead to this diagnosis, as well as cancer and the use of drugs to treat cancer. And so patients who have a history of steroid use, excessive alcohol consumption, or have a history of cancer in the past that were treated with chemotherapy and have new onset hip pain, it is something that we just need to keep in mind. Hip fracture. So particularly at Valley, this is something that we see very, very frequently. And so this is a diagnosis typically of osteoporosis or of the more geriatric population. It's usually secondary to low energy falls. And so patients with osteoporosis will have a fall in the home and ultimately it'll lead to a hip fracture. And so there's really two types of hip fractures that we typically see, and they're treated somewhat differently. And so if you have any friends or family or know anybody that had a hip fracture, they either were treated with a rod inside of the nail or inside of the bone, holding the bone in place, or a hip replacement. And ultimately, it depends where the fracture occurs. And so all hip fractures are not equal. All hip fractures are not the same. It really depends. It's an umbrella term for several different varieties of fractures, and ultimately your surgeon determines what the appropriate treatment for you is. The goal of treating a hip fracture is to get patients up and ambulating as soon as possible. And so typically a hip fracture, about 95% of the time does require surgery. And typically we like to perform that surgery within the first 24 to 48 hours. Now, osteoarthritis. This is really where we're going to focus the rest of our talk. And this is really what the majority of my practice is focused on. And so hip arthritis is an incredibly common disorder, and it's caused by loss of cartilage And so the cartilage is the smooth cap on the end of the bones. And in our hip joint, that entails the smooth cap over the ball, as well as the smooth cap lining the socket. And so generally, those two bones are able to glide very perfectly together and have in a ball and socket joint because of that smooth cartilage. When we start to lose that cartilage, that leads to pain, inflammation, and ultimately some of the things that we'll show you here shortly. So generally, osteoarthritis is progressive, so it occurs over a very prolonged period of time. It's not something that happens acutely. And so this is something that develops over many, many years. The causes of it are multifactorial, meaning there's not one specific cause. It can be caused by obesity or being overweight. Genetics certainly plays a role in this diagnosis. A history of trauma or injury to the hip. Patients that have had some sort of injury leading to an instability of that ball and socket joint. So it's no longer functioning out as it was designed. And then certainly the older we get, the higher likelihood we have of developing osteoarthritis. So how do I know if I'm starting to develop arthritis? Well, generally, you start to develop pain deep within the groin, or also in the kind of in the posterior butt area, or when you sit, that area kind of right deep within the butt. And the pain is typically going to be initially just with activity, and then slowly as it progresses, you will start to feel it at nighttime as well. You're also going to oftentimes notice stiffness in the hip. And so what that often means is patients describe difficulty, say, putting their shoes and socks on, getting in and out of a car, getting in and out of bed. And it's that motion of bringing the hip upwards towards your chest that really becomes limited. Most patients have developed slowly over many, many years. There are some cases where it will develop more rapidly, but that's certainly the exception and not the rule. If we look specifically at age in relation to arthritis, patients 75 years and older, more than 50% of them will have a diagnosis of arthritis. So it certainly is a diagnosis of aging. Here we just have both an X-ray as well as a schematic of what arthritis really is. And so if we look here on the left, this is an X-ray of a normal hip. So we see a very nice round ball, and then we see a nice socket that the ball fits into. When we go to this picture on the right, we can see now we have bone spurs, and we've lost that nice space in between the ball and the socket. And so the cartilage is what lives in that space that we can't see on X-ray. And so when we've lost that cartilage, we now have the bone directly rubbing on the bone. And that is what leads to the pain and inflammation. I oftentimes describe it as when it becomes very severe and you have large bone spurs, it's almost like putting a square peg into a round hole, as we've now developed these bony areas off of the round ball. And so that leads to the stiffness and the inability to move the hip the way that we used to. You can see the same schematic over here where we have the nice smooth white cartilage in a normal hip joint versus now the very rough jagged edges with the bone spurs. And that's what we're seeing typically when we go in there and look at the hip at the time of surgery. So is there a cure for osteoarthritis? Unfortunately, in 2025, we still do not have a cure for osteoarthritis. Our treatment at this time still aims at managing your symptoms and slowing the progression of the disease, but we have no reversal agent for the disease. And the surgical options at this time really involve removing the arthritic parts of the joint and replacing them with metal and plastic, which is your hip replacement. So how do we relieve hip arthritis or the symptoms associated with hip arthritis without surgery? First and foremost, and always the first step in treatment, is exercise and physical therapy. Physical therapy can be a tremendous first step in treatment. And the reason is multifactorial, but in general, the idea is that by restoring the strength of the muscles around the hip joint, what they're able to do is start to dissipate that force that travels through the hip joint. If the hip joint sees less force traveling through it, then it's going to ultimately have less of a reaction and ultimately less pain. And so muscle strength is one of the most important modalities in improving arthritis pain anywhere in the body, but particularly the hip. Additionally, physical therapy can start to improve the range of motion and flexibility of the hip joint. And the more mobile the hip joint is, the less symptomatic you're going to be, and more able to do many of the activities that you are hoping to perform. Um, Unfortunately, when you do develop severe bone-on-bone arthritis, exercise can actually aggravate the symptoms rather than help improve them. And so that's when speaking with your surgeon about whether you're past the point of needing this type of treatment is important. Another thing that I always stress to my patients is the importance of weight loss. So weight gain not only increases the pain associated with your arthritis, but it can increase the rate of progression of your arthritis, and it can be a causative factor for the development of the arthritis. And again, that's primarily because our joints have what I would call a tolerance. And so they're designed to see a certain amount of stress. And if our body has too much weight on it, then too much stress goes through that joint, and the cartilage is not designed to tolerate that stress. And so it starts to wear down. So the heavier you are, the joint is consistently and constantly seeing more and more stress, and it wears down quicker. And so if we can take weight off, we can start to slow down that progression. And more so, we can actually decrease the pain associated with the arthritis, again, because we're not putting so much stress through the joints. And even a little bit of a weight loss can make a big difference, because we put around 5 times our body weight goes through our lower extremity joints. So if you lose 10 pounds, that's 50 less pounds that go through that hip joint. And that can mean a tremendous difference with regards to symptoms. Medication. So this is going to be our oral anti-inflammatory medications that we use for symptomatic management. We typically start with over-the-counter oral anti-inflammatories. This is going to be your things like Tylenol, ibuprofen, and naproxen. And so what these do is they work to reduce the inflammation that's caused by the grinding within the hip joint, which can reduce some of the pain associated with that. And then if over-the-counter anti-inflammatories are not effective, we have several prescription strength anti-inflammatories that are oftentimes a little bit more effective. The two that I most commonly like to prescribe are meloxicam and diclofenac. We do have to be careful with these, though. They can irritate the lining of the stomach if they're used excessively. And also patients that are on blood thinners or have high blood pressure that is not treated can have some contraindications to these medications. If you do have a contraindication or unable to tolerate NSAIDs, Tylenol is your best bet. So Tylenol works in a different mechanism than all of the other medications here on this screen. It's a little bit lower intensity anti-inflammatory, and it doesn't irritate the stomach. And so patients that aren't unable to take NSAIDs for a variety of reasons, we recommend Tylenol, and it still is effective. The other thing I would like to note here is that it's very safe to take Tylenol in combination with any of these other medications. You don't want to take any of these other ones combined with each other, but Tylenol plus any one of these is very effective, and actually is much more effective than either one by itself. After we try physical therapy and anti-inflammatory medication and potentially weight loss, if the symptoms persist, the next discussion can be about injection therapy. And in general, this would involve a cortisone injection. So cortisone is a type of steroid, and steroids are our most potent type of anti-inflammatory. And again, very similar to the oral anti-inflammatories, this reduces the inflammation within the joint and ultimately can reduce pain, except this is locally injected just into the hip joint, and so we're not getting the systemic effects, and so it can typically be a little bit more targeted and achieve more symptomatic relief. Unfortunately, when we're talking about the hip, cortisone injections are usually only helpful for a brief period of time. We can give injections in other joints that are typically a little bit more effective. So if we're talking about the knee or the hands, or even the feet, cortisone injections oftentimes provide some pretty long-lasting relief. For whatever reason, we don't really know why. Cortisone injections in the hip just don't seem to be as effective. But Some people are candidates, some people are not interested in surgery, some people are in a period where they just want to try something. And I certainly do see symptomatic relief. Unfortunately, it usually just doesn't last very long. I have here also viscosupplementation injections. This is most frequently used in the knee. The literature or the evidence to support the use of these in the hip is very, very small. And I'm not a big proponent of these because it's relatively invasive to do an injection into the hip. It can be uncomfortable, and the positive effects from the injections are very minimal. So, is surgery right for me? Well, first off, have you tried physical therapy? Are you actively exercising? Have you lost weight if you're in that category? Have you tried anti-inflammatory medications? And have you had a discussion about injection therapy with your surgeon? If you've done all of these things and you're still having pain in your hip, and that means, again, deep-seated groin pain, as well as pain that will be in your posterior buttock, which will occasionally travel down to the knee. The other thing to really understand about hip arthritis is that it can be referred down the thigh to about the level of the knee. Hip pain or hip arthritis should never cause pain that travels past the knee. So if you're having pain that travels past the knee into the calf or the foot or the ankle, that's most likely coming from either your back or somewhere lower down than the hip. But you can certainly have pain in the thigh and the knee that is secondary to hip arthritis. So if we have a diagnosis of arthritis, we've tried all of these things I previously mentioned, and you're still unable to do the things that you want to do, you need to do, or you enjoy doing because of this discomfort and limitations, and your quality of life is impacted, that's when you become a candidate for hip replacement surgery. I really describe hip replacement surgery as a quality of life procedure. It restores your ability to do the things that you, again, want to do, need to do, or even enjoy doing on a daily basis to give you the freedom to live your life. And so if that's the case, we should have a discussion about hip replacement surgery. So if we see here this schematic here, essentially what we've done is we're removing the old ball and we're reshaping the socket and replacing it with titanium and plastic. And that gives us two perfectly smooth surfaces that can now rub together to provide you a painless range of motion of your hip and restore the hip you had prior to the development of arthritis. So how long does hip replacement surgery take? In general, it takes somewhere between an hour and an hour and a half. This is an X-ray, again, of a hip replacement, where we put some metal into the bone. That's going to hold our new ball. And then we've got a brand new socket that the ball can articulate with. A very common question I get is, will I need general anesthesia for this procedure? And in about 95% of cases, the answer is no. We use regional anesthesia, otherwise known as spinal anesthesia, or what many of you may know as an epidural. So basically, it's one anesthetic shot in the back, similar to what patients get for childbirth. And essentially, it numbs you from the lower abdomen down. And then the anesthesiologist gives you some medicine to put you to sleep, but you're still breathing on your own. And that's a much, much safer way of doing the procedure as opposed to general anesthesia. It reduces postoperative nausea, it reduces postoperative urinary retention, and it also decreases postoperative pain levels. And what this really does is it allows us to get patients up and moving very, very quickly after surgery. The spinal anesthesia wears off after about 2 hours. So in general, 15 to 20 minutes after the surgery, patients are already moving their legs and they're awake and alert because they did not receive general anesthesia. And so within an hour after surgery, you can be up and walking. And ultimately, what that means for you is a quicker recovery, less time in the hospital, and more time at home. How long will I be in the hospital? So For me, for my patients, about 50% of the patients go home the same day as surgery. And so that's typically within about 3 or 4 hours after surgery. That's going to be my young, motivated patients that are healthy and have good social support at home. Patients that either live alone, are a little bit older, have more medical comorbidities that we want to keep an eye on, will stay one night in the hospital and they go home the following day sometime around lunchtime. And those patients will work with physical therapy once in the afternoon after surgery, the following morning, and then they go home. Now, what surgical approach will I use? So this is a very, very frequent question that I get, and I think most patients are aware of, or have at least heard of the idea of the posterior approach and the anterior approach for hip replacement, or the hip replacement from the back and the hip replacement from the front. And now, in reality, there's many different approaches that the surgeon can use to access the hip joint and perform a hip replacement. But certainly, the most two common ways are the posterior and the direct anterior. And I would say that the posterior is the more conventional or classical approach. That was the initial way that the hip replacement was described since the 1960s. Much more recently, surgeons have been utilizing the direct anterior approach, and this is the approach that I use. This is a muscle sparing approach, so it's minimally invasive and it's a smaller incision. And the incision is on the front of the hip as opposed to through the butt. So again, we can see here that there's the posterior or the approach to the back. There's this lateral approach or the through the side, and the anterior is the one here on the front of the hip. So why do I do a direct anterior approach? First of all, it's much more minimally invasive. So the incision for me is somewhere between 3 and 4 inches. In general, it's going to be about the length from my pinky to my index finger there. And so that you can compare that up to between 6 and 12 inches for the posterior approach. So it's a much smaller incision, which means a smaller scar, and most patients enjoy that. It also allows us to be incredibly accurate with positioning of our hip replacement components. And one of the main reasons for this is that we can use X-ray machine intraoperatively to see our components, ensure that they are positioned exactly where we like them. When you do this surgery through the other approaches, particularly the ones in the back, the patient is on their side during surgery, and so utilizing X-ray is not really feasible. And so we're kind of guessing a little bit with our positioning in that case, versus with this approach, we can be 100% certain we're putting our components where we want them. Direct anterior approach has also been shown to result in a quicker recovery. And this is honestly probably the main reason that I prefer this approach. So patients are able to get off of their walker at a much quicker rate than patients that have a post-op or a posterior approach. Getting off of the cane is also about a week sooner than the posterior approach. Pain control, so there's much less pain after the anterior approach, and we'll touch on to why that is here shortly. The functionality of the patient, so again, their ability to go up and down stairs, walk without an assisted device is much quicker in the anterior approach. And then their endurance and their ability to ambulate long distances is better as well. We can see here the incision for the anterior approach. So I perform it in 2 ways. The standard anterior approach, this is here. This is a right thigh. This is the patient's front, and this is their back. And we can see it kind of right here on the front, and that's probably about 4 inches, a longitudinal incision. I also perform what we call a bikini incision, and that's more so in my females, and that's actually a horizontal incision that goes just below the hip flexion crease. So if you were to wear a bikini after this incision, the bikini would actually cover that incision and no one would even know that you had a hip replacement. So why the quicker recovery when we're doing the anterior approach? Well, the main reason is because this is what we call muscle sparing. The more traditional posterior approach, you have to cut several of the muscles and tendons off of the bone in order to expose the hip joint. And while this gives us good exposure, it ultimately leads to a lot more pain. By cutting the muscles and tendons off of the bone, they have to heal back onto the bone, and that leads to a lot more pain and functional loss in the early postoperative period. Now, when we do the anterior approach, we're able to actually just push the muscles to the side, and we don't have to cut any muscles or tendons off of the bone. So this leads to less pain and more functionality because we don't have to wait for those tendons to heal. Another really favorable thing about the anterior approach is that we don't have to use any postoperative hip precautions. So many of you, if you had any friends or family or know anybody that underwent a hip replacement surgery and had a posterior approach, you might have heard them talk to you about how they had to make sure that they couldn't bend over or tie their shoes, they couldn't sit in a low chair, or they maybe even had to sleep with a pillow in between their legs for the first 6 weeks. And the reason is that we have to let those muscles heal to the tendons or the tendons heal to the bone, which I was describing. And before that happens, the hip is very unstable and can potentially pop out of place. With the anterior approach, because we're not cutting any tendons off of the bone, we don't have to worry about that. So I let my patients really return to all activities, all motions, without sleeping with a pillow immediately. And they certainly do appreciate that. The other beautiful thing about the anterior replacement is patients really do not necessitate or require physical therapy postoperatively. Again, because all we're doing is moving the muscles to the side, everything functions normally immediately after surgery. And so most patients, as long as they do a home walking program and they're up and walking every day, they're able to regain their strength relatively quickly and not need any formal physical therapy. So just to reiterate the benefits of the direct anterior approach and why I feel like it's so beneficial, there's going to be less pain in the early postoperative period, better mobility in the early postoperative period. Most of my patients will be on a walker for somewhere between 3 and 7 days. They'll progress to a cane for about a week. And at their first postoperative visit, 2 weeks after surgery, the majority of patients are walking into the office without any sort of assistive device and probably a small limp. You go home from the hospital sooner with the anterior hip replacement, less pain medication, obviously because of the less pain, don't require extensive physical therapy, and a big one, you don't require any hip precautions. So no sleeping with a pillow, no being concerned about bending over or sitting too low and the hip popping out of place. Of course, with any surgery, there's always a risk. And with the direct anterior approach, the primary risk that we worry about is getting some numbness on the outside part of your thigh. The nerve that gives you sensation on the part of your thigh, on the outside part of your thigh, can oftentimes get stretched. The nice thing about this is first off, it almost always resolves. And number two, there's no functional consequence to this. The primary complaint that patients might often tell me is that they don't hear their phone buzz when it's in their pocket. In reality, maybe that's actually a good thing. How long does it take to recover? So following a direct anterior hip replacement, again, you should expect to walk with a cane or a walker for about 2 weeks after surgery. By about 6 weeks, most patients are back to doing most activities without any limitations. They might still get a little bit fatigued by the end of the day. They might have a little bit of soreness with strenuous activity, but by 6 weeks, most patients are able to return to most activities with just some mild limitations. And by 3 months, most patients return to all activities without any restrictions. And something that's pretty profound, and I see very, very frequently after hip replacement surgery, is that even on the day of surgery, so within an hour and a half after the surgery is over, you're up and walking, that arthritis pain is gone, and so that deep achy nuisance of a pain you've been dealing with for the past several years, that's immediately gone. You're going to have certainly some muscle soreness, achiness from the surgery itself, but that improves relatively quickly. And so this is the type of procedure that almost immediately you notice a significant improvement in your symptoms. Another very common question I get is, when can I drive? And so it will depend a little bit on which leg. So if it's the right leg, which is certainly going to be your gas pedal leg, it's a little bit longer. In those patients, it's somewhere on average between 2 and 4 weeks. If it's your left leg, it's usually somewhere between 1 and 3 weeks. What about returning to work? What I usually tell patients is If it's a sedentary job, well, if you can work from home within a couple days. If it's a sedentary job where you're sitting at a desk, but you can get up and to do your walking program every hour for about 5 minutes, then within a couple weeks. If it's the type of job where you're on your feet for most of the day, but you can sit occasionally as needed, but you need to be able to be on your feet for 8 hours a day, usually somewhere around 8 weeks. And if it's a more demanding labor type job, where you're on your feet, you're lifting, you're climbing, you're squatting, you're kneeling, that's going to be around 3 months. Like we had mentioned previously, will I need physical therapy? I don't require my patients to go to physical therapy after hip replacement surgery. So for the first 2 weeks, we specifically just do a home walking program. After 2 weeks, we have a discussion with the patient in the office about whether they want the therapy or not. And in general, it's not necessarily because they need it, but it's because it's a motivating tool. It's a tactic to get out of the house and start to do some things. And that's generally why we elect to do therapy. But if you're motivated, you have a good support at home, you have a gym you can go to, you certainly do not require physical therapy. How long will the hip replacement last? Well, what I want to tell you is it's not 10 to 20 years, which is what most patients always quote me as. And I still am not 100% sure where this data came from. For as long as I've known, that has not been true. It's one of those kind of misquoted things that has just passed through society. But hip replacements have a durability of about a failure rate of 0.5 to 1% per year. So what does that mean? So that means in 20 years, you still have an 80 to 85% chance your hip is well functioning. In 30 years, you still have a 70 to 75% chance your hip is well functioning. So for the vast, vast majority of patients, your hip replacement will outlive you. So what we should not be worrying about in anybody over really the age of 50 is that your hip is going to wear out. Now, for the very rare patients that we do hip replacements in much younger patients, the youngest I've ever done is a 19-year-old. Then that's a different discussion. But that's certainly the very, very rare case. For the majority of patients with our osteoarthritis, you do not need to worry about your hip replacement wearing out. What will my hip feel like? By 3 months, you're not going to even know you had hip replacement. You might get a little bit sore, but you're going to be able to do all the things that you were used to do without any limitations. And something that a term that we have in orthopedics is called the forgotten joint score. And basically it means the percentage of patients that after 2 years cannot remember which joint they had replaced. If they didn't have the scar or actually remember the surgery itself, but strictly based on how it feels. The forgotten joint score for a hip replacement, a well-done hip replacement, is about 85%. So after 2 years, if you ask a patient which hip they had replaced, they couldn't tell you just based on how it felt. That's how much we restore their native function. And then lastly, is a joint replacement worth it? Well, a common way to measure the value of a procedure is to compare the cost to the quality years of life it gives a person. So the cost of surgery, if you look from a financial standpoint, certainly may be high, but the improvement to quality of life is great and it's sustained and it competes the money spent upfront on the procedure very, very clearly. And so your general sense of health, your well-being, your quality of life all improve tremendously. And what I quote patients is for a hip replacement surgery, 98% of patients afterwards are very satisfied. That means they return to all activities without limitations. And this says 9 out of 10. For hip replacement, it's more like 98 out of 100 people say they would do it again. And frequently they say they just wish that they did it sooner. So that's the end of the talk, and certainly I would love to answer some questions now if anybody has anything with regards to different diagnoses, different types of hip pain, reasons for hip pain, treatment for hip pain, questions about hip replacement surgery, anything that may have come up.
Okay, well, we've had some great questions come in, and this is just to let people know you can submit your questions in the Q&A portal at the bottom of your Zoom screen. The first one is, does a labrum injury lead to arthritis?
So it depends. In general, there's two types of labral injuries. So there is acute traumatic labral injuries, which is generally going to be in the younger population. Um, those injuries, if they are not going to go on to lead to the development of arthritis, meaning if you treat them non-operatively and your symptoms go away, you do not have to worry about fixing it to prevent the development of arthritis. But what can be a little bit confusing is the other type of labral tear, which is what we call a degenerative labral tear. And so that is what we see in older patients, usually 50 and above. And so as you begin to develop arthritis, that leads to the development of a labral tear as well. So very frequently, we will see a labral tear in conjunction with arthritis. It's not that the labral tear caused the arthritis, it's actually that the arthritis caused the labral tear. So I think that to answer the question, labral tears do not cause arthritis. Actually, arthritis will cause labral tears.
Okay. Can knee or hip arthritis cause tingling or numbness in the leg?
The short answer is no. So tingling or numbness in the leg is most frequently associated with some sort of nerve damage, probably coming from your lower back. Now, the caveat to that is we all can have very varying degrees and different sensations that are associated with pain. So some patients will have pain, and that will lead to a brief period of numbness or tingling, and that's more from just the pain sensation itself. But if you have sustained numbness and tingling in the same area consistently, that's most likely related to a nerve coming from your lower back that's damaged.
Okay. What about topical creams like Voltaren?
So those can be very effective as anti-inflammatories to help with pain. I'll say they're usually much more effective for knee arthritis as opposed to hip arthritis. And that's just because the hip joint is very deep within the groin, and so the topical creams can't really work their way down there. With that being said, for the diagnosis of bursitis, which we talked about in the beginning, which is your pain on the outside part of the hip, the Voltaren can be quite effective for that.
Okay. And for cortisone injections, how many are advisable?
So the big question is going to be how positive response you get to the first one. So if you have a very favorable response to one injection and it gives you a year's worth of relief, certainly I would recommend doing another one if you want to avoid surgery. Now, if you do a cortisone injection and you get a couple months worth of relief or not even that long, I would not advise doing another one. And the primary reason is because the recovery from the hip replacement is so quick and it's so easy that unless there's a very real reason, very specific reason you can't go forward with the surgery, it's best to just do it, get better, and not have to worry about it. We're just kicking the can down the road with these injections, which aren't really effective. But if you have a very positive response, then it is very reasonable to discuss continuing those. It's just that that's pretty infrequent in the case of hips.
Okay. I'm going to combine a couple questions here. So what would be the first step in determining a need for medication, surgery, and then the diagnostic test would point a surgeon to a specific treatment
Yeah,
plan? They're kind of one and the same.
yeah. So we always start off with an X-ray. And so for the vast majority of diagnoses, a physical exam and an X-ray is going to provide all the information I need to make the diagnosis. Very infrequently do we need MRIs of the hip, but if we do an X-ray and then we typically trial a course of conservative treatment and we're still having pain and there isn't arthritis in the hip, then we will obtain an MRI, and that's usually looking for either a labral tear or severe tendonitis. But I would say MRIs of the hip are relatively infrequent because usually X-ray and clinical exam can provide the diagnosis.
Okay. And someone would want to know whom at Valley should they make an appointment with. So
No, you
it
can make
would
an
be
appointment with me.
exactly. Um, so there's um, okay, is groin pain always associated with your hip?
No, there certainly are other things in the groin. So that would typically be like a hernia. And so there's a few different types of hernias. There's hernias where that would need to be treated by a general surgeon. There's also something called sports hernias, which can be treated by an orthopedic surgeon. Um, but when we're talking, also you could have tendonitis in your groin as well, which could be outside of the hip joint. So uh, that involves a physical exam and a history obtained by the physician to try and kind of delineate that, and then occasionally either X-rays or an MRI. But other than the hip joint, there's tendons as well as a potential hernia in the groin that could cause pain.
Okay, how soon can you fly after surgery?
So it depends on the duration. I typically recommend trying to avoid flying for 4 weeks if possible. If it's something very important and it's going to be a relatively short flight within 2 or 3 hours, I'm okay going about a week or two before that. We do have you on a blood thinner just in case. But I like to say 4 weeks is kind of my ideal amount of time before flying.
And how about stairs? Can someone do stairs right away, or do they have to wait a
Yep,
while?
before you leave the hospital or the surgery center, you're doing stairs. So you'll be doing those within an hour after the surgery. You'll be doing it a little bit slower than typical, obviously, but there's no reason that you can't go up and down the stairs.
Okay, and when is ball socket resurfacing indicated?
So that's somewhat of a nuanced question. Nowadays, very few surgeons are actually doing resurfacing procedures. It's really reserved for very high level athletes. And the reason for that is the current literature suggests that in the layperson, not very high level athlete, like professional athletes, the functional difference between a hip replacement and a resurfacing procedure is negligible or not noticeable. And so the hip replacement is a much technically easier procedure, has an incredibly long longevity. And so for 99.5% of the population, hip replacement is just as effective. And it's technically an easier procedure with a greater longevity. So very few surgeons do those anymore. It was kind of in vogue in the early 2000s, but it's fallen out of favor with the newer literature.
Does osteoarthritis appear bilaterally? You mentioned replacing one hip, so does that mean both hips um, will need to be replaced, or do they go at the same time?
So arthritis certainly can present bilaterally, but it does not always present bilaterally because the etiology or the reason that we develop arthritis is so multifactorial that sometimes it's one hip, sometimes it's both, sometimes it's one, and then the next one 5, 10 years later. Sometimes it's only one, sometimes it's both at the same time. That's very variable between patients.
Okay, can sleeping with a pillow between your legs help alleviate hip pain?
It's going to depend on your diagnosis, just because hip pain is such a broad topic as we discussed. So it certainly can't hurt anything. So if you want to try it and see if it helps, there's no harm in that. But it's really going to depend on what the diagnosis is. But also, everybody's a little bit different. But there's certainly no harm in trying it.
Okay, and this question was related, I think, to the over-the-counter medications that you mentioned earlier. How should the over-the-counter dosage be managed?
Well, sure. Certainly, it's going to depend on the medication. I can kind of go through these. Um, okay. So Aleve is typically that's a twice day medication. So that's going to be 200 milligrams typically daily or 220 milligrams daily. Motrin, I usually recommend 600 to 800 milligrams 3 times a day. Usually these come in 200 milligram tablets, so you can take 3 to 4 of them 2 times or 3 times a day. Mobic is a once a day pill. So this is a very common medication that I like to prescribe as a prescription strength. It's easy to take. It's just once a day. And you can either have 7.5 or 15 milligrams. Celebrex is also a favorite one of mine, and that's it's twice a day, and it's either 100 milligrams or 200 milligrams. But these are going to be prescribed by your doctor. And then Tylenol is a 3 times a day pill as well. And I usually recommend 1,000 milligrams 3 times a day. So patients often come and are concerned about taking too much Tylenol. It's really very difficult to take too much Tylenol. You have to take about 4,000 milligrams a day very consistently to cause liver damage. And so I usually say 3,000 is very, very safe. And you can even go above that for brief periods of time and be just fine. And you can combine the Tylenol with these other ones all at their full strengths, and it's all very safe.
Okay, for using back to Voltaren, can someone use that for years if it helps, or is it?
Yeah, that's very safe. I'm not aware of any literature showing that prolonged use of that has any deleterious effects.
Okay, would you consider an 89-year-old sedentary, unmotivated person as a candidate for surgery?
Well, I would have until you said unmotivated, because that's really the key here. What are we doing the surgery for if you're not motivated to get better? So this is a quality of life procedure. So we're trying to restore your quality of life, get you to do the things that you want to do. If you don't have a motivation to do those things, then why are we here? 89 and sedentary. So the age, the number is not really nearly as important as, so it's not your chronologic age, it's your physiologic age. And so it's your health status, your other medical comorbidities. I have 92-year-old patients that are healthier than 55-year-old patients. And so it's not the age, it actually is your motivation, it's your functional level, and it's your list of other medical comorbidities. But if you're not motivated, then I'm not doing it. Then what are we doing it for?
Okay, so there's a question here about weak pelvic floor. Um, and I'm not sure if this is a question related to, is it hip pain or pelvic floor issues? Can a weak pelvic floor make your pelvis feel like it's being pulled apart from each side?
Hmm. Yeah, I'd say that's a little bit out of my wheelhouse. I could imagine it would, um, but yeah, I really don't have a good answer for that one, unfortunately.
Okay. And there are a couple comments about people wondering if they're candidates for hip replacement. So, for instance, if someone has had hip pain on and off, but if they rest, the pain goes away. Um,
Mhm.
would that make them a candidate for pain if they only feel it sometimes?
Yeah, I mean, certainly, if you meet all the other criteria, and so certainly you have advanced arthritis, and if that pain while you're active is very limiting and affects your quality of life, then certainly you're a candidate. Very frequently in the setting of arthritis, hip pain is going to resolve with rest. So by no means does that mean that you're not a candidate if it's affecting your ability to do the things that you want to do when you are active.
Okay. And someone who has a history of uh, labral tear, bursitis, tendonitis, are there exercises to avoid? So
To
they used to be a
avoid,
runner. Yeah, and they cycle and walk, but could that be
yeah,
exacerbating pain?
yeah. So it's a little bit challenging just because the type of tendonitis, the location of the bursitis can be variable, and so there certainly are specific movements that can irritate specific tendons. That's a little bit challenging to answer in a general form. That would really need to be specific to the specific diagnoses, unfortunately.
Okay, and our last question is about gel shots again. Is it dangerous? And is
They're
there a
not.
success rate? Hmm?
Yeah, so gel, they're not dangerous. They're very, very safe. The only risk associated with gel shots is potential for allergy, which is exceedingly rare. So they're very safe. The problem just is that in the hip, the efficacy is not any better than placebo. Meaning, if you were to inject saline or water into the hip, or stick a needle in there and not inject anything, versus if you compare that to patients who got a gel jet injection, there's no difference. So if you look at large literature studies, and there's always the risk with, we put it in order to do a hip injection, it's a little bit different than doing like a knee or a hand or a shoulder. We have to bring into the surgical suite. We have to use X-ray machine. So it's relatively invasive. It's more time consuming, and the effectiveness is no better than placebo. So it's not a great option for hip arthritis.
Okay, I think that's all our questions and our time for this evening. Thank you so much, Dr. Zachwieja.